Well, hepatobiliary really, so it's all the liver, pancreas, and the bile ducts is primarily what I'm focused on. It's a fascinating area of surgery because there's both cancers, so malignancies, and also benign disease, which we treat. So, for example, we treat everything from injuries of the bile duct, which could be from trauma or surgery, to cancers of the bile duct, the pancreas, the liver, of course. And then within the pancreas, we also treat benign diseases, which could be cysts, could be autoimmune diseases of the pancreas, which cause scarring and stricturing, recurrent inflammation of the pancreas, which can actually make people very sick, and even in this day and age have a very high short and long-term consequence, with patients even dying from these diseases. Many times patients who have pancreas disease have seen a number of different doctors, sometimes over several months or even up to a year, trying to get a diagnosis and figure out exactly what's going on. So often by the time they see our team here at Tulane, we have a pretty good idea of the fundamental workup that's been done, and the patients have a better awareness of their disease. But normally a patient would present with things like nausea, vomiting, pain in the upper abdomen that radiates to the back, which could range from mild to severe. It could come in waves or episodes. So, for example, some patients might be feeling just fine for 2 or 3 weeks at a time, and then just all of a sudden have an episode which really lays them out and prevents them from going to work. So they usually start with their general practitioner, and then typically do get referred to a gastroenterologist. Most gastroenterologists have a basic understanding of pancreas type diseases, but there are a set of gastroenterologists who do additional training. We usually call them interventional gastroenterologists. And interestingly enough, their training is 7 years, which is the same amount of time that my training was. So the surgeons and these advanced gastroenterologists are really very specialized. And we're fortunate here at Tulane to have put together a team or a group that not only includes the gastroenterologist, the surgeon like myself, but also dietitians, pain management experts, and for people who have cancer, both chemotherapy doctors and radiation oncologists in the cancer center. So it's a wide range of people. That's one of the things that I find really exciting about being a surgeon who deals with the pancreas. We have a whole array of different things we can do depending upon what the specific problem is. So, for example, there are some patients who have chronic scarring of the pancreas, and for those patients we actually typically do surgeries where we try to fix something. For example, the pancreas makes digestive enzymes, and if you have scarring and narrowing of the drainage duct that takes the pancreas enzymes out, they back up. And so we can actually basically do plumbing type of surgery where we reconnect those ducts to the intestines. It may require removing small parts of the pancreas, but really what we're looking at is redoing those connections. On the other hand, if we have things that we think might be malignant or precancer, then those, of course, we want to remove, and we do resections for those. And with the modern technology, we have surgical approaches that range from minimally invasive, laparoscopic, robotic assisted, all the way to more major traditional open surgeries. So we have a whole array of different things we can do. It is one of the challenges with pancreas surgery is that by the time the patients get to see somebody like myself, the disease unfortunately sometimes tends to be fairly advanced. Now, if we catch people earlier, a lot of times we can do curative surgery. If we catch people later in the course of the disease, then what we're really trying to do is give them the best outcome possible. What we like to say is that we want to do the right surgery for the right patient at the right time. So we develop a relationship with the patient. figure out exactly what the diagnosis is, explain the treatment options, and then when they're optimized for surgery, do a procedure which we hope will, if it's malignant, give them the best chance at a long-term cure, or if it's one of the more chronic pancreatitis type of processes, that it'll get them back to as close to a normal functioning life as possible. In the latter case, nowadays, with the right treatment options, we usually figure that about 80 to 85% of the patients will report that they have a very good to excellent outcome, where they've really basically gotten back to normal.